Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill and I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be a really interesting and important session. And I should say the session will be recorded, so if you miss a little bit, you can always get it on catch up. There are so many things that are within your control and so many things that are outside of your control that can have an impact on whether IVF works for you or not. Some of them are fundamental and apply to everyone, and many are very specific to your particular circumstances. And I think tonight is going to be one of those, probably one of the most frequently asked questions by IVF patients. I'm joined tonight by a fantastic set of panelists who are here to help you better understand what factors will affect my IVF success. They are Dr. Lenka Hromadová, Chief Medical Officer and Head of IVF at Repromeda in the Czech Republic. Dr. Federica Moffa, Medical Director at Fertilab in Spain.
Hi.
And Dr. Ioannis Zervomanolakis, Partner at Hygeia IVF and MITERA Hospital and Head of Southeastern Fertility Solutions in Greece.
Good evening, everybody.
Thank you. I normally ask some general questions, but I think this topic is so general and so broad, and I think you'll have so many questions that I'm hoping they start coming in very soon. So I won't ask those normal questions to get us on the same page. If I see an absence, I've got some already lined up, but I'm hoping we'll cover what you as the patient can do to give yourself the best chances and what the clinic can do and the relative importance of each. If I can ask you please to put your questions in the Q&A box, the question and answer box, not the chat, that will help us to deal with all of them. We'll try to answer all of them, but I'll prioritize ones that are easy to generalize, that haven't already been answered, and those that stick to tonight's topic, just in the interest of time. So let's start by, okay, we've got a question already in. That's fantastic. I started losing weight as I have a BMI of 34 and previous transfers have failed after 2 weeks. In case I lose 10 kilograms, 5 to 10% of my weight, do I still need Zoladex treatment? And there's a specific milligram dose there, as I got a start of, I think that's adenomyosis. So let me ask Dr. Lenka that question.
Yeah, I guess that adenomyosis can be the reason of the implantation failure. So if the patient has already started the treatment, I would like her to, or I would recommend her to continue. So according to my opinion, I would recommend to use Zoladex or another agonist, another medicine like this to be used about 3 months at least.
Okay, fantastic. Do any of the other doctors have a different view? That's the first question. And if not, I'd like to ask whether you want to make any general comments about losing weight for IVF. So. Or being at an optimal weight. So Dr. Federica, do you want to say anything about weight? Because I think that might be quite a useful thing.
Yeah, I think that we have now evidence that if we can try in some patients natural cycle for embryo transfer, especially in patients with adenomyosis, so reducing the need for hormone replacement treatment, in some cases, we can have an advantage. But of course, so if the patient is losing weight, probably her cycle and her period will be more regular. And we can maybe try, as an alternative, we can try the natural cycle. And having a BMI below 30 in general can help for implantation.
Okay, lovely. Thank you. Dr. Ioannis, do you want to say anything about so we've gone from reducing our BMI. What about, I know this is not the question, but I want to kind of generalize, having an optimal BMI, not too low, not being too skinny, in other words. Do you want to say something about that, please?
The first question that arises is how regular the cycle of the patient is. So the second question is also the fact that it could be combined with PCOS. So by losing weight, even up to 10%, the possibility that the patient gets a regular cycle is higher. And I'm sure that if we start with a stimulation, regardless the medication that they're going to use, the results are going to be better as far as the number as well as the quality of the oocytes is concerned.
Okay, thank you. I'm going to stick with you and ask the next question, and we can go through again. What's the best preparation before embryo transfer with Hashimoto syndrome, adenomyosis, and age 39?
Should I go for the answer then?
Yes, please. Yes. Sorry,
okay.
Yes.
It depends on the value of TSH. If we have a TSH of around 1, it's fine, and we could proceed with embryo transfer. What we also do in our clinic, according to our experience, is that we give the patients saline as well as prednisolone 5 milligram tablets once daily, because Hashimoto is an autoimmune disease. So if we really take this aspect into consideration, by giving corticosteroids even in such low doses, we're going to help implantation then.
Okay, thank you. Any difference of opinion from the other doctors?
I think that especially in this patient with an autoimmune disease like Hashimoto, we know that artificial preparation for embryo transfer, so the use of estrogens, can maybe increase the level of TSH. So when it's applicable, of course, when the patient has a regular period, again, imagine that these women, 39, but even later, we use even in egg recipients, we use natural cycle as a first line preparation, endometrial preparation treatments. And when we observe that when the patient have a thyroid issue, this is really the best option to reduce also miscarriage risk.
Okay, thank you. Dr. Lenka, do you want to add anything, or?
No, I absolutely agree that the natural cycle is the best option for the patient. We don't use prednisolone very often because we believe that it can be harmful for the embryo implantation because of the immune system directly in the womb. And so the TSH should be in the normal ranges.
Okay, thank you.
Mm-hmm.
We've got a question here. It's quite specific, and I'm going to ask the questioner to put a bit more detail in because I think it will help. So this is the person who's asked, I'm 34, did IVF in Thessaloniki, froze 4 embryos. One is graded 2AB. Can you tell us, I'm assuming they're day 5 or day 6, but can you tell us that, please? And the other grades, if you've got them, and what, so we can let this one sort of ruminate in the doctor's heads. What chance do we have for an FET, frozen embryo transfer? What success rate? But I think we need to know a little bit more about the other embryos, and maybe a little bit more about previous history as well. You know, whether you've had other embryos and other transfers in the past. Before we come to that, because otherwise I think there's too much information missing. So if you wouldn't mind adding some information to that, would be great. So, Dr. Lenka, after IVF treatment, can I expect a regular period after all the medications have finished? And when? Does it affect my period going forward?
The stimulation, ovarian stimulation, can affect the period, the regularity of the period. But according to my opinion, it takes only next month. Next cycle is usually irregular. Than the other menstrual cycles are usually as regular as before starting the treatment.
So would we all agree that about a month is what we would leave?
Yeah.
Okay, perfect. Okay, thank you. Okay, Dr. Federica, how much can the donor's blood type influence post-assisted fertilization, loss of pregnancy, abortions with egg donation? So I think that means the egg donor, yes.
Yeah, I should say no influence on implantation rates. Of course, the only situation where we have to take care of blood group matching is when the recipient is O negative and make sure that she doesn't have irregular antibodies, cum test positive, but otherwise there is no impact on implantation success rate if depending on the blood type of the donor.
Okay, perfect. This might be this is from the dim and distant past, and I'm not a medic, don't forget. So this is not specifically this question, but is related to using a donor. Can the blood type influence things like preeclampsia? Is there some evidence on that?
Nice question. Maybe, but it's very open debate. Whether, yeah, but it's we actually in our program, and we have a big egg donor and recipient program. We don't do blood group matching based on this variable because the evidence is so strong.
Okay, and I can see from the shaking of heads and things that yes, there's not strong evidence for anyone to worry about the donor blood group, apart from what you said about the O negative. So Dr. Ioannis, how many days, I mean, this is a very simple question, but sometimes simple questions are best. How many days after embryo transfer should you check for positive pregnancy? And I guess the question is also saying, is a urine test good enough, or should it be a blood test, or anything else? Do you want to give a kind of an overview?
Thanks for the question. I always perform a blood test because it helps me understand how the implantation has gone so far. We usually perform the blood test 9 days after the blastocyst transfer. So we start from day 0, which is the day of the fertilization of the oocytes. If we perform a frozen embryo transfer, it depends on the day during which the embryo is frozen. If it's a day 5 embryo, like a blastocyst, as I said before, we perform the blood test on day 9 after the embryo transfer. If it is a day 3 transfer, which is not so often anymore, we perform it on day 11. And by having the value of HCG, we can also predict, let's say, how the implantation has gone. Apart from that, in Greece, we are allowed to perform an embryo transfer of 2 embryos. So another point that we have to take into consideration is the value of HCG depending on the number of embryos that we have transferred. So this is the reason why we usually perform the blood test on this specific day.
Okay. Thank you. That's really clear. So just to summarize then, urine test is okay, but it's a binary test, isn't it? So I've got a line or I haven't got a line. Blood test gives us values which can tell us a little bit more about the pregnancy. Right? Is that fair?
Exactly.
Perfect. Thank you. Let's go back to Federica. Can you please give me some understanding of a chaotic embryo? I've had my second PGTA test. I'm sure that's what that is. The first one last cycle was abnormal, and the second one this cycle is chaotic. From the question, I can only see that there's 2 embryos, but there may be other embryos, but let's just stick with those. So do you want to say something about what a chaotic embryo is based on how people report?
I mean, we always have to remember that when we do PGTA, we are doing the biopsy or 4 or 5 cells, and we receive the results of the genetic test. And sometimes the chaotic results, it should always be retested. because it can give us different results. So rebiopsy. So we normally used to repeat the biopsy. So we have to thaw the embryos, of course, and then rebiopsy. And we have some of those will came out normal embryos. Yeah.
Thank you.
Maybe. Yeah.
Maybe, yeah. Does anyone else want to? This happens to be my specialist subject. So,
yeah, that's why I was waiting for you.
No. But
I try to refrain from the embryo transfer. To be honest, I wouldn't transfer it. I don't have any good feelings by doing it.
Okay.
I would retest, and if it's normal, I transfer, of course.
Okay, Dr. Lenka, do you have anything to say about this?
Yeah, so what do you mean by the term chaotic embryo? So is it a mosaic embryo or?
Obviously, it depends on the laboratory that's done the test. So whatever I say now is only based on what I think it means, based on what we used to report in our laboratory. And that is that there are multiple chromosome abnormalities such that, you can't really interpret it properly, because otherwise it would just be multiple chromosome abnormalities. So, so let me leave that with you, and then I've got something I'd like to say afterwards.
We don't use to test, retest embryo with multiple chromosome abnormalities. So we, our description or the description of embryos coming from our genetic lab is euploid, aneuploid, mosaic, or embryo with segmental aneuploidy. And if we see that the embryo has multiple chromosome abnormalities, we don't retest it.
Okay, perfect. Thank you. Without getting too technical, I just got a LinkedIn message from someone today talking about a publication that just came out in Fertility and Sterility, and it's kind of a review type paper based on the history of PGTA, and it's essentially saying we may have been very hasty about how we classify embryos based on the result. And I haven't read it yet. I've just seen some comments about it, but I think probably one of the categories, chaotic embryo, for example, might be that if they're very clearly abnormalities and all of our other controls in the laboratory have worked, then probably this is an abnormal embryo. If it's a result where we don't have anything else we can call it, and it just doesn't make sense, it might not be abnormal as we originally thought. So I think rebiopsy is potentially a good idea. This doesn't work in every clinic and every laboratory for obvious reasons, but it's something we need to consider again. And there may be questions on mosaic embryos later. Consider this: a few years ago, if somebody got a mosaic result, it's a good chance the embryo wouldn't be transferred. And now what we know today about mosaic embryos, there's a very good chance it would be transferred. So things change. The embryo hasn't really changed, just the way we classify it and the way we understand it. So I certainly wouldn't throw away an embryo where I didn't really understand the result. And that's not criticizing any response we've had today from the doctors. The truth is we don't have that report in front of us, so we don't necessarily know exactly what it means. So I would definitely go back to my clinic, who should go back to the laboratory and say, define exactly what chaotic means and how confident you are about that result, because that's an embryo. Okay. Let's just see. Yep, we've done that one. Okay. I've lost my place. So we were on. Let's say Dr. Lenka now, please. After 2 failed IVF and 1 miscarriage, we decided to go for egg transfer. I think that probably means egg donation, but I'm going to have to guess that it means egg donation. What are the main differences? What things do they have to consider? And can you describe how much better you think the chances will be? We don't have the patient's age there, so we can't make that determination. But what would you like to say about egg donation as opposed to using your own eggs?
It depends after 2. So you said two implantation failures and 1 miscarriage.
Well, it says 2 failed IVF. It's not specific, but and one miscarriage. Yeah.
Yeah, so it depends on the age, I guess. So this is the most important factor, I think. If it is a young lady, I would prefer to make some additional tests to discover what wrong can be in the body. So the uterine abnormalities, coagulation disorders, immune system disorders, microbiome, etc., etc. If it is a woman about or above 40, I would probably recommend to undergo the egg donation. But if the PTTA has not been done before, even if no matter if it is a young lady or a woman in the advanced reproductive age, I would recommend PGTA. So it can be the reason of the implantation failure and the miscarriage, of course.
Perfect. So what you're saying is there's things that we can do when you're using your own eggs without having to resort to egg donation straight away. Yeah, perfect.
Yeah.
Also, I'm gonna pass this one to Dr. Federica. So, well, actually, I should make a general comment to all of the audience. Actually, it's really helpful if you put in particularly the female age when you're asking a question, because that immediately kind of grounds us to what your chances are. So that's really important. And that's kind of an overarching theme of tonight, that female age is really important in this equation of what your success is likely to be. But now we're going to make an assumption here, which may not be true for this patient who asked the question, but let's just assume she's actually quite young. So can you say something about the male part of this? Because that could have an impact, right?
Yeah, actually, it's something that we observe when couples come maybe to Spain for egg donation after many IVF failures, and the time, the woman's age, of course, is already a big problem, but they started maybe when she was 35 and now she's 40 and they had failures. And so the eggs is the first things that we want to change to increase the possibility. But we observe sometimes that the male factor is not investigated enough, and then we sometimes have some egg donation cycle with poor results, and that's why I think that a deep understanding on the male factor is important, especially when you think that you maybe change one of the gametes. You have to make sure that you're changing the right one. So there is a big debate also on the chromosomal pattern of the sperm. Yeah.
Okay, perfect. So yeah, I mean, essentially the male factor part does have an important role. But often we go straight to looking at the female age because that kind of trumps most other things usually, doesn't it? If we see an advanced age, then we kind of say, okay, well, let's fix that part first. Let's worry about that part first. Okay, I had a question that looks quite, I don't know, it looks quite not too specific, but actually, where is it? Sorry, just trying to find it. And this is for Dr. Ioannis. Here we go. Sorry. There's lots of questions now, which is great. It's about blood tests. So, here we go. Yeah, my wife had some blood tests, doesn't specify which, but we can talk generally, undertaken 3 years ago, and she wants to now undergo egg donation treatment. Will she need to undergo these tests again? So I think the two parts of the question that I would like you to answer are, if she was using her own eggs originally, what tests would she need to do again, if any? And if she's done egg donation before, are the tests that she had before still valid? And maybe think in terms of, you know, the category of tests: hormone tests, other tests, and maybe infectious disease.
Of course, if the patient uses her own eggs, we have to repeat the hormones again. And the most important reliable factor of the ovarian reserve is the anti-Müllerian hormone. I always perform the estimation of anti-Müllerian hormone every 6 months, to be honest, especially if the patient gets older, because it helps me plan the stimulation and decide if I have to repeat the same protocol as I did before or not. Regarding patients that undergo oocyte donation, we have to check hepatitis, HIV, syphilis, etc. Nevertheless, it's also important to take into consideration if this patient has undergone thrombophilia screening before, because most of women that decide for egg donation have had their negative results in the past. So we have to find out if there is any other factor except for the ovarian reserve that has led to the implantation failure. So I always go for hepatitis, etc. Nevertheless, I perform the thrombophilia screening as well in case the patient hasn't had these results before.
So let's say she's had all the tests before, but it was 3 years ago. There's a really nice answer about the AMH, like every 6 months, give or take. But for these other things, are they good for 3 years, or should we be repeating these tests?
It depends on the fact that they were okay or not in the past. If she had a positive thrombophilia screening, I would perform the treatment with heparin and low-dose aspirin in any case. So, as I told you before, it depends on the results themselves.
Okay. Anything to add from the other doctors?
It depends also on the legislation. Some tests we need to repeat. The serology tests, it depends. In Spain, when you have a new fertilization treatment, even if it's with egg donors, the recipient also, she has to undergo to repeat serology, viral.
You mean infectious disease testing?
Infectious disease, yeah.
Yeah, perfect. Okay. Yeah, okay. So there's things, again, beyond clinic control, isn't there? There's things that you don't get to choose. I know it must seem to patients sometimes like they're being over-tested, but some of it is outside of the clinic's control. So that's really important. Okay. Okay, Dr. Lenka, what options for IVF stimulation do we have for patients with low ovarian reserve?
It depends. So I usually check AMH level and also AFC, so antral follicle count. And even if the AMH level is low, and if I can see by the ultrasound more AFC or the bigger AFC, more antral follicles, let's say about 6, 8, 10, I recommend to give the patient or to start with a short protocol, antagonist protocol, and give a higher daily dose of gonadotropins. So we use recombinant gonadotropins usually in women. Women with low ovarian reserve are given or are administered FSH plus LH hormone, and I give, let's say, 450 as the maximum. But if I see the low number of antral follicles, I think it does not make sense to give so high daily dose of gonadotropins, and then I usually decrease the dose to, let's say, 300 to 250 units, because it does not make sense if we cannot see antral follicles or so many antral follicles. It doesn't make any sense to push the ovarian stimulation with very high doses.
Okay, do we from the other doctors, do we have any difference of opinion or other ideas? Because I seem to remember in some other sessions that we've done, there's been lots of other interesting things about ovarian rejuvenation, and I don't want to get too much into that, but is there anything else that people are, let's say, currently using, not read about, but using that would be different for patients with low reserve?
Yeah.
Dr. Ioannis, start with you. Yeah.
Federica, ladies first. Federica, it's your turn, and then I will go.
Anyway, so we all know that it's a big challenge for fertility doctors to stimulate a poor responder. I think it's very important to know if the follicular phase is very short. We used to give estrogen priming in the luteal phase of the previous cycle to try to avoid just one dominant follicle to lead in the follicular phase during stimulation. And of course, we apply strategy as the dual stim and also the double trigger when we induce ovulation. So those are kind of strategies. And in some patients, we also use, we went back to the long protocol, giving GnRH agonist from mid-luteal phase of the previous cycle, yes, to avoid this early recruitment of the dominant follicle.
Okay,
Yeah,
thank you.
it is the option to give, for example, nose spray. Yeah, yeah.
The protein.
Okay, Dr. Ioannis, you had something to add, please.
Actually, we go for a mild IVF. We use 150 units daily in an antagonist protocol. Sometimes we add either clomiphene or letrozole. The most important thing is to be able to take, let's say, a low number of good quality oocytes. So the way to achieve it is something that has to do with the experience that everybody has in the past. But in our country, we are in favor of mild IVF and duostim as well. We don't perform a long protocol. I don't think that there is anybody that performs long protocol anymore.
Okay, so I'm going to ask it in a rather naive and ignorant way, just to make it a bit clearer for everybody. When I first started in IVF as an embryologist, so that's like 25 years ago, I remember people, well, older ladies and therefore some of them having poor ovarian reserve by nature of being older, being given tons and tons of drugs, really highly stimulated. Is that pretty much out of fashion now? That doesn't really happen anymore. So that's a good thing, isn't it? That's very good, yeah, for cost and safety reasons and efficacy reasons. So, Dr. Federica, we've got some more information from that patient who asked the question earlier. So they're 34, they did IVF in Thessaloniki, they froze 4 embryos, and this is really critical. This is why it's really important to give as much information as possible, because it really changes the picture. So we heard about an embryo that was 2AB, and I was thinking, this doesn't sound very promising. All the others are 4AA. Yes, wow. Exactly. So look at her face, look at my face. You've given us more information, and we're like, okay, this is a different story.
Okay. Okay.
So you've got 3 4AA and 1 2AB. So let's answer the question first. What do you think this, on average, and every doctor can answer this from their clinic, 34-year-old, ignoring any other problems because we haven't got that information there, what sort of chances would this patient have with these embryos?
First of all, I would like to have this patient in my clinic. Second, I guess that the overall chance to have a newborn, because I think that we always have to speak with patient giving success rate in terms of live birth. This is a little bit of my opinion. But so if we have 4 embryos and we have 3 4AA and 1 2AB, I think that the overall live birth rate of the cycle is around 80% delivery rate. This is the rate that we have with this kind of embryos in egg recipient with egg donor. So to me, if there is no other problem, no uterine problem, they can have 80% chance of live birth, to me.
Perfect. Well, I can see everybody else.
Sorry?
Go on. No, go ahead.
So with, of course, repeated single embryo transfer. So.
Okay, and I can see everyone nodding, so that's great. So I guess that everybody pretty much agrees. We don't need to quibble about a couple of percent here and there. I think why the picture changed to this questionnaire was when you said we've got 1,2AB, I'm sure that was weighing on your mind, like, oh, I've got this 1,2AB. And in your mind, it's not as good as the others. And maybe it's not, but maybe it's just a little bit delayed compared to the others. We don't know. But it's very good news that you have 3 4AAs. That's the point, right? That's the really important point here. I think reading the question, I thought you had 1 2AB and everything else was worse. And if that were the case, I think your chances would have been much, much lower. I think we probably agree on that. Okay. So I would say don't worry about the 2AB, and labeling an embryo doesn't actually change it. Giving it a name doesn't change it. Okay. It's just a rough and ready grading system to try and help us prioritize. And if you wanted an answer about what embryo to transfer first, it would be not the 2AB, right? That's the simple answer. Okay.
Good.
Okay, good. But we're all happy, we're all smiling, so you should be smiling too. Okay. Dr. Lenka, I'm a 47-year-old female. I've been through several IVF failures. I'm in good health. I've got an AMH of 2.6 and regular cycles. Can I go for another IVF attempt?
Oh, the lady can try, but I guess that the embryo quality will be quite low. Yeah, so I don't know whether she experienced to get blastocysts before. So it depends. Yeah. So women above 40 hardly get blastocysts because of the quality of oocytes. So, and the quality of oocytes is given by the age. So with the increasing age, the quality of oocytes decreases dramatically, and in the age above 40, 42, there is only one egg among out of 10 which can form a blastocyst. So and if we get blastocyst in this age, most probably it is aneuploid. So in the advanced reproductive age, we always recommend to do PGTA. And if we have top quality blastocysts, of course, suitable for the biopsy. So, yeah, I guess that if the lady experienced the blastocysts before, she can try, but the probability of getting pregnant, of getting promising embryo is very, very, very low.
Okay, perfect. I'm going to ask everybody a very specific question, and you don't need to add anything to it unless you really, really want to. Honest answers, please. I know you'll be honest with me. I think a simpler way to answer this question for a patient who comes into your clinic is to answer the following question. Have you had any live births from 47-year-olds in your clinic? If the answer is yes, nod your head. Never. Okay, so it doesn't mean it's impossible. It just means it's extremely unlikely. So you'll always find a clinic, maybe not the guys here, you'll always find a clinic that will take your money and take your patronage to do a cycle if you really insist. But the best clinic is the one that's going to give you the most honest answer and tell you whether they've succeeded before. So I'm not seeing anyone nodding for a 47-year-old.
No,
but it's never happened.
Yeah, no, and then we don't do IVF over 45, even if the patient asks for, independently of the AMH level or any other variable. So we don't perform IVF, we don't eggs after 45. 44, over 44, not 45.
We strongly recommend not to do it. But if, so maybe you told that the AMH level is 2.6, but it depends in in which units it is measured. So if it is nanogram per milliliter, then it should be quite a big ovarian reserve. But if it is picomole, then the ovarian reserve is very low, and then it does not make sense, of course, any longer.
Okay, so, and I think this came up in quite a few other sessions I've hosted. This idea of what's futile treatment. At what point do you say to a patient, no, we just can't do this? And many of the doctors who've been on these previous sessions have said, look, if they really insist, if they got some factors in their favor, we might consider it. But that's why I'm cutting through it and asking the question, in this clinic, have you ever succeeded? So if you think you're going to be the first patient that succeeds in that clinic, great, but I think the numbers don't lie and the history doesn't lie. So I'm sorry if that's not the news you wanted, but I think it's really important to have that honest appraisal. Okay. So, Dr. Ioannis, I'm a patient here. In November, patients can be 51 using donor eggs. And actually, we've had some questions from this patient already. So, if I lose 10 kilograms, do you think I could try with my own eggs? I mean, that's pretty much the same question,
Never.
isn't it?
The same question, the same answer. But I would like to take the opportunity to tell you about our experience in Greece, because in Greece, we are allowed to perform IVF treatment with egg donation until the 54th year of age, under current conditions, including breast screening, cardiological screening, etc. And I had a talk last week in our national conference. In our clinic, we have performed 77 embryo transfers of women between 50 and 54 last year, 2023. And we had a pregnancy rate, a positive HCG test of over 60%. So this is something that shows how important the egg quality of the donor is. And regardless how old the recipient is, if the uterus, the uterine cavity looks normal, and if we perform the appropriate preparation of endometrium, we can achieve a pregnancy.
Thank you. That's really helpful and really useful to know. And I'm going to give the other doctors
I was
an opportunity.
Also surprised by the results. I haven't ever expected that the positive tests would be so many, but this is the fact.
I mean, I'm not a doctor, but I'm not surprised by those results. Honestly, I'm not convinced that the reason the age limits are in place in countries are because of success rate. I think they're to do with other things. But let me ask Dr. Federica and then Dr. Lenka, what is it in your clinic and what is it in your country for egg donation age limit, please?
For the recipient, the age, there is no limit by the law. In Spain, there is no age limit, so we be allowed to have recipient, let's say, any age, but they should have be in good health and low obstetric risk of complications. So in our clinic, we set a limit at 50, with some exception up to 51, if maybe the patient already had a pregnancy and she still have a frozen embryo, we can open. But we try to stick with 51 maximum. Yeah.
And why is that?
This is because of the risk of complication. And I think that little by little, we will put these limits a little bit higher. But of course, we know that the risk, higher risk of premature delivery, preeclampsia, and complication. I don't know if Dr. Ioannis, this 60% pregnancy mean 60% delivery rate. So I'm curious.
We are waiting for the baby take-home rate because, as I told you before, it has to do with last year, and in our country we had this high age limit only since 2 years ago. So we are also expecting for the results of all clinics, and then we can talk about how safe a pregnancy at this age is.
Okay, thank you. Dr. Lenka, what is it in your clinic and in Czech Republic, please?
There is a limit, 49 years in the Czech Republic, both for the IVF with own eggs or donated eggs. It doesn't matter.
Okay,
49.
thank you.
Mm-hmm.
Yep, that's really clear. So let's. This is for. I'm going to ask Dr. Federica this one. Can stress be a significant causal factor in miscarriage post-blastocyst transfer for a patient aged 40? I'm going to assume here, because it doesn't say, that the transfer is using an embryo that's recently made, you know, at that age, rather than one that's been sitting in storage for a long time.
Mm-hmm. Yeah. Okay. If a patient of 40 years old transferring a blastocyst with their own egg and then at miscarriage, stress as poor impact. So we have to assume that chromosomal abnormalities are the main cause of the miscarriage. So the impact of stress is very little, unfortunately.
Okay, thank you. Yeah, I agree. It's one of those things where we can't rule out any of these other factors, but you have to look for the most likely factor, and the most likely factor is chromosome abnormality, right? Okay, perfect. Dr. Lenka, is it better to do a 2 embryo or a single embryo transfer, and why? So I think you're going to have to give the risks. You're going to have to talk about risks a little bit, please.
More than 10 years, we have been transferring only 1 embryo. We do everything to make possible to give a birth to a healthy child. So it does not make sense to transfer only 1 embryo, because if we transfer more than 1 embryo, then the probability of multiple pregnancy is quite high, and the multiple pregnancy or during the multiple pregnancy, there is a very high risk to give a birth very early, and babies are born immature, and they can be seriously ill, and they can even die because of the prematurity, and the multiple pregnancy can also adversely affect the pregnant woman. So with the multiple pregnancy, serious diseases can be connected, like preeclampsia, high blood pressure, diabetes, etc.
Perfect, thank you. Anyone want to add anything else on? Well, actually, let me just ask a different way. What's the percentage of embryo transfers, single embryo transfers in Spain, would you say approximately these days? Because I think it's a similar story around Europe and globally, isn't it?
You ask in Spain the proportion of single embryo transfer. I would say more than 90% of the transfer are single embryo transfer. But of course, there are different clinics and etc. But I can tell that in our clinic we have 97% of single embryo transfer, no matter if it's IVF with own eggs or egg donor.
Perfect. And the reason I'm sort of, we all know there's always exceptions to the rules. There's always patients who need something slightly different. But I think asking these questions and saying, honestly, in your clinic, what happens really? And you say 97% of the time this happens. I think that sends a strong message to people about what the best practice is. What about in your clinic and in Greece, Dr. Ioannis?
It's at least 60%. Nevertheless, when we have older patients that go with their own eggs, they're 42, 43, then we go for a double embryo transfer, to be honest.
Okay.
It depends on the age of the patient.
Okay, perfect. Thank you. And sticking with you, Dr. Ioannis, I'm just saying that looks like a bit like a question we've already. No, I'm going to move on from that one because I think that's already been asked in a different way. What's the optimum progesterone level post embryo transfer? Let's start with that one, please.
Some clinics or some doctors measure progesterone level. I don't measure progesterone level, to be honest. I give both vaginal as well as subcutaneous progesterone, and I don't measure it. Some doctors say that we need at least 12, a level of 12, let's say, in order to say that the progesterone level is sufficient.
Okay, perfect. Any of the other doctors got a different opinion? Sorry, I was just writing something in the chat if I looked distracted.
Actually, we always test progesterone level before transfer, but of course we just give vaginal, and if it's below 12, we add the subcutaneous. And of course, it depends if it's a natural cycle. So if the patient is producing herself the progesterone because of the ovulation, or if it's an artificial cycle. Of course, we find more cycles that need supplementation with subcutaneous when it's an artificial cycle. And we test again the progesterone level at the day of the pregnancy test with BTCG. And if it's below 14, we add the supplementation. So there are studies, especially coming from Labarta and the EV group, showing that it's very important to keep a good level in the implantation window, and then also in the early phase of pregnancy to reduce miscarriage rates.
Okay, thank you very much. I'm just going to make a couple of comments because I've seen something in the questions which is more like a chat. So this is to the lady who asked about the chaotic embryo. I've put and this is for everyone, including the doctors. I've put the reference for the paper in the chat. Okay, so if you look through the chat, you'll see something I've just written. So if you click on that, you'll find the paper. I think it's quite accessible as a paper compared to lots of other really scientific papers. So I think it's worth a read for anybody who's either offering PGTA, the doctors, or receiving PGTA, the patients. And you've added, my doctor doesn't want to do a rebiopsy. I would question that. That's all I would say. As a coach, that's the kind of thing I speak to patients about and say, what do you want to do? Why have you been given that answer? Question it, because it might just be, we don't do that. That's our policy, not to rebiopsy. Or you may get a really good answer, which is, we've done it before and the embryos never survive. That would be a good answer. But you want to sniff out a good or a bad answer and work out where you want to go from there. Okay, so Dr. Lenka, after embryo transfer, what precautions should you take to ensure that you don't get a miscarriage? And are there any supplements you can take to avoid miscarriage?
So it depends. It is necessary to, as we previously talked about progesterone. So it is necessary to have enough of progesterone, or to have good progesterone level, and if there are, for example, some coagulation disorders, I would recommend to use low molecular heparin, or yes. So I'm just thinking about recommendations, other recommendations. So we recommend to use vitamins, prenatal vitamins, myoinositol. It depends. So it is very individual. So I would have to know more about the lady, to recommend what is necessary to, or what could be helpful to be used after the embryo transfer.
Okay, and I do appreciate that it's difficult to give very specific advice when you don't have all the information. I feel the same way when I'm reading the question, trying to work out how we can generalize it. I'll stick with you for this question because it's kind of similar. So it's a patient who suffered from depression. I understand we haven't got all the information, but if we can generalize it, can we say if somebody's about to have, or they're having a donor embryo transfer in a few months and they're concerned about depression, are there particular antidepressants and mood stabilizers that they should keep away from that we know are contraindicated for an embryo transfer, or not?
Usually we perform embryo transfer even in ladies who take antidepressant medication, but it depends on the recommendation of the psychiatrist. So we ask for the recommendation for the help of the psychiatric specialist, and if the doctor recommends, so because the doctor knows the health status of woman very well, so it depends on the doctor's recommendation, the specialist's recommendation. But the medication can be used even during the pregnancy.
Okay, perfect. I'm seeing lots of nodding, so that's good. Dr. Ioannis, because I know you do some, or you've talked about day 3 transfer, so I think this is a relevant question for you. So lady here, age 44, would you recommend freeze and transfer all at day 3 or push to blastocyst? I know there's an it depends part to this, obviously, but what can you make some generalized comments about that as well, please?
Well, it depends on the number of the available embryos. If we have let's say more than 4 embryos on day 3 that are of good quality, we go until day 5. If the number of available embryos is lower, we would consider day 3 embryo transfer as well. Nevertheless, when we have the consultation with our embryologist, we say that we perform the embryo transfer on day 3, and we let the rest embryos in the culture medium until day 5, and then we decide if we freeze them or not.
Okay, perfect. And I'm kind of assuming that the other doctors are largely sort of exclusively pushing to blastocyst in day 5, or am I wrong about that? Are there any, maybe we can turn it the other way around. Are there any situations, any conditions under which you would do everything at day 3?
Maybe just one egg, one embryo, and the patient that we perform a lot of PGTA. So in the rare case where we just have one embryo and we know that the patient will not go for PGTA, we maybe discuss with the patient. But I don't remember last time I transferred a 3-day embryo. So
okay, so that's another one of those things where I said, what actually happens in your clinic? You go, it doesn't happen. So if someone's looking for a day 3 transfer, they're probably not going to come to your clinic, or probably one in Spain. I mean, I don't think Spain does a lot of day 3 anymore. I think that's fair to say, but I'm not 100% sure about that.
No, I mean, there is room for day 3 sometimes, and there are clinics and groups that are different philosophy. But again, I think it's going to very little number of situations, because with own egg IVF, we perform over 36, 37, mainly PGTA, so very little number of day 3.
Okay, perfect. I'm going to stick with you because this question is sort of related, but I think I'll probably go to the other docs as well to broaden the conversation, because I think there's layers to this question. So this patient had an unsuccessful FET. I'm translating it, of probably day 3 embryos. There were 4 embryos and they were transferred all at the same time. So that already is, unusual in some countries, I would say, due to age 43, and none took. So it was a failed cycle. I'm wondering if putting all 4 of them was a mistake. Now, leave to one side the risks and whether that's allowed in your country. We're just talking about the kind of science of it, the biology of it. So the patient's asking, I think it's a really good question. Would there have been a better chance of survival if they weren't all transferred together? And the science bit that sticks in my head is there any evidence that transferring embryos together when one of them or more of them are abnormal might actually have an impact on one of the normal ones? I know it's
this is a very nice question. So to me, I would prefer to go to blastocyst, of course, if we have for day 3, especially in the 43 years old. But let's say that we are not able to go to blastocyst and we have for day 3. There are, if I remember, studies that suggest that the crosstalk between the uterus and an abnormal embryos can alter the receptivity of the endometrium. So if we maybe have 2 abnormal embryos and no, it's 43, let's say that we have 3 abnormal and 1 normal, maybe the conversation between the embryos and the uterus is a bad conversation, because the signals that the abnormal embryos are giving to the endometrium affects also the receptivity for the good one. I don't know if I gave an answer.
No, I think it's a really, really clear answer. So to answer that patient's question in one way, at least, is there's a chance that if you transfer them all at once, the abnormal ones, of which there must be some because she's 43, but there almost certainly will be some, might have affected, if there was a normal one, they might have affected that. On the other hand, there's a good chance they were all abnormal at age 43, right? There's a good chance, so it wasn't going to work anyway. And on the other side of that is, if you transfer them one at a time and they're all abnormal, let's say they weren't tested, then you're just wasting quite a few months of transfers, right? So that, I think that kind of summarizes it quite nicely. If either of the other doctors want to add anything there, please do, because this is a super interesting question.
No. As I told you before, I perform a twin pregnancy, double pregnancy, double embryo transfer. But when patients ask me if the one embryo affects the other, I admit that I say that I don't think so. If we have only
and the
two.
truth is, the truth is we don't know for sure, right? So we can't really say for sure. But there is, I agree. I've heard some evidence. Weak evidence is not easy to compare. You'd almost have to do a study where you knowingly transferred abnormal embryos, and you'd have to do that kind of thing to see what happened. Okay, so I think this has kind of already been answered. If you have 3 embryos at the age of 44, should you transfer all of them? Well, not necessarily all at the same time, for the same reason we just discussed. At what point should you give up on your own eggs and consider donation? I think we answered that earlier, where 44, you're on the cusp. It's a question of what success rates have people had using their own eggs at that clinic, age 44, 45, 46, and so on. So you're definitely on the borderline there. I think we answered that one earlier. How quickly can you start another round of IVF after a failed transfer or failed round? Wait a month. Would that be fair to say? Yep. Not sure. Okay. I think, what are the possibilities if you just entered menopause? I think, is that just
egg donation? Yes.
Yeah, I think it's
donation,
just donation question, isn't it?
Yeah. Couldn't be possible otherwise.
If you don't feel like we're answering the questions properly, pop something in the chat and say, no, I meant this, because I'm just trying to work through them. Okay, right, it's quite a long one here. Okay, I'm not sure I understand that one. Sorry, too much information there. Okay, Dr. Lenka, I'm 43, ovarian reserve of 1.4 picomoles per liter. Good, we've got the units there. Serum FSH of 7.6 IUs per liter. Serum LH 4.3. Progesterone 26.4 nanomoles per liter. What are my chances of success using my own eggs? How can my treatment be optimized?
What is the age? 43. 43. And FSH 7 point something.
7.6.
AMH.
AMH 1.4 picomoles.
Yeah, so I guess the chance is very, very low. Yeah, because so this is the very poor ovarian reserve, I guess, and related to the age, the quality of eggs will be unfortunately very low. So in this case, I would recommend to try better egg donation.
Okay, perfect. Thank you. Let me just go back to the questions. Working through these really nicely. Okay, Dr. Ioannis, what can explain early fragmentation of all of my embryos? I'm 40. I've been through 2 IVFs with good response to stimulation, 6 embryos the first time, 9 embryos the second time, all of which fragmented early. 4 in the first cycle and 8 in the second cycle. It says dying at day 2, but I guess becoming very fragmented and not reaching blastocyst. What options does this patient have if they're getting fragmentation and no blastocyst development for 2 cycles?
Let me tell you what I perform in my clinic. When I have such an experience with the patient, I ask myself how the egg quality is and how the egg quality, the poor egg quality, has led to such a result. And what I do is I try to change the protocol then. So since we don't have any information about the protocol, the medication that this patient received, I couldn't make a comment on it. I would change the medication that this patient takes and go for another stimulation. She mentions that she has a relative appropriate number of eggs collected, so I think that she deserves one more chance. But I would change the stimulation protocol.
Okay. Perfect. Okay, I see a few questions that are similar. So I'm going to ask that to Dr. Federica. Endometrial microbiome, and I think it's focusing on lactobacillus. Okay, these questions. Obviously, there's other microbes that we need to be concerned about if they're pathogenic, but it's saying, I was told it needs to be 90% or predominantly lactobacillus. Mine is lower, 40%. How can I get it to 90%? And does it even matter? I've added that, and does it even matter? Okay.
Okay, so it seems to be evident that healthy microbiota with predominance of lactobacillus around 90% is the best microbiota, and there are studies comparing the fertile population with the infertile population that differs. So it seems to be very important, but sometimes it's very difficult to reach this 90% with treatments. Of course, we give oral and vaginal lactobacillus and probiotics. And in our clinics, we test the microbiota just in case of failure. We don't test it as a first line diagnosis, but yes, I think that it's important to try to correct this and to reach a better rate of microbe or lactobacillus presence.
So how confident are you about the evidence for that, or is it more a case of it's unlikely to be harmful to do it?
I recently participated in the Spanish national meeting, and of course there are scientists that are coming out, of course, with doubt if really what we are thinking we have to see inside the uterine cavity, or of course in the vagina, if it's really something that we have no reference. So we think that it should be this 90%, but maybe we don't know this 100%. So, as you said, maybe we know that healthy microbiota and the absence of pathogens, it's very important. State that 90% is strictly the limits. I'm not sure today.
Okay, thanks for that. Dr. Ioannis, I'm 42. We've just gone through IVF with PGTA. We had 5 embryos biopsied. 1 is euploid. So I think the key thing here is it says, should we try to find more euploid embryos in future cycles, or just go with this 1? I think the key here is that they're 42. Should they transfer the embryo now, or should they try and bank some more euploid embryos?
I would go for an egg stimulation, to be honest, in order to make sure that we have a higher number of euploid embryos and perform a frozen embryo transfer later. I wouldn't lose time since this patient is in advanced stage, and I don't want to go for a stimulation, let's say 6 months later or something like that. The sooner we get the embryos, the better the outcome of the treatment is going to be. That's why I would repeat the stimulation, go for next biopsy with more embryos, and then decide for a frozen embryo transfer after the results.
Okay, thank you. Got a question here. It's really very detailed and very long, very interesting, but you know, it's been difficult trying to read it while we're doing this. I'm going to apologies, because I'm going to have to sort of cut it a bit shorter, because I think honestly this is the sort of thing where you need to speak in detail to a clinic or to a coach or to somebody, because there's so many layers to this, there's so many bits. But this is a lady who's had a pregnancy with a C-section in the past. How long do they have to wait for another pregnancy to be safe after a C-section? Dr. Lenka.
I guess that from, let's say, about 8 months, from 8 to 12 months, it should be the safe period. If the C-section is okay, if the ultrasound of the uterus shows a normal picture, no thinner uterine wall.
Okay, perfect. Thank you for that. And then it really is quite a detailed question. I'm not criticizing it. I'm just saying there's sort of too many bits to it. But maybe I can ask in a more generalized way. Do you have in each country, so we'll start with you, Dr. Lenka in Czech, do you have any laws that cover the use of sperm after the man has died? So all the consents are in place and everything. And the reason I ask that is not necessarily what the law is, but if there isn't a law, sometimes it's a bit grey about what you can and can't do. So is it normal practice, if all the consents are in place, to be able to use, you know, a lady who's widowed to use sperm from a dead husband if the consents are in place?
Unfortunately not.
Okay.
It's not possible.
Spain, yes.
Okay. What about if the embryos are already, if there are already embryos that exist?
We cannot transfer embryo which already exists after the death. Unfortunately.
Okay, perfect. So that's really clear. Thank you. I don't think this is answering this patient's all of their questions in total, because there's a lot of questions, but that's really useful because it kind of closes the door and means that you can focus elsewhere. But you're right to ask the question. There's a lot of different laws and regulations in different countries around Europe, so it does make your situation quite complex. So Federica, sorry, you were saying about Spain.
Yeah, no, sorry. In Spain, it's possible, but of course, you need the previous consent of the couple. So, couple, they always sign if whether the husband will allow, in case of death, to the partner, the woman, to transfer embryo or to use the sperm in the 12 months after death. So this consent, the widow should decide to undergo the treatment within 12 months after the death.
That's another interesting, it's like it's permissive, but to a point. That's really interesting. So that's use of sperm or embryos created by that sperm. Yeah. What's the situation in Greece? Yeah, sure. What's the situation in Greece?
We also need to have a consent of the couple through a notary. So we need a notary for that. If there is no consent, we're not allowed to use either sperm or oocytes or embryos.
Okay, from what I can see in the question, obviously I don't know the nuances of notarization and stuff, but and I'm certainly not promoting the UK here, but we've had quite a few cases in the last 20, 30 years. And the law has almost been created by that case law in terms of people posthumously using sperm from their husband or partner who passed away. And the need for consent was obviously paramount. But there were nuances about what that consent looked like. But to my understanding, if it's written consent that's completely understandable and it was used in a clinic in a European country, it's probably good enough. But I would certainly want to find out more about it. And I think that's something, if you want to afterwards, you could message me privately and we could dig into that a little bit more, because as I said, there's lots of layers to it and it's not usually a simple answer. And I think Federica's answer is perfect in the sense that, oh yeah, it's okay, but it has to be within 12 months. I wasn't expecting that. So that's, a bit of a surprise to me. So I hope that's been somewhat helpful. I know it hasn't answered the question perfectly, but okay. Right. Dr. Lenka, I'm 30 years old. I've just done my egg collection, 5 embryos, 2 day 3, 8 to 9 cells, 2 day 5, a 3 AA and a 4 BB. So good quality, and 1 day 6, 5 BB. What do you think about the quality of my embryos? Oh, I just said it. I've spoiler alert. I'm currently preparing for my frozen embryo transfer. This is my first stimulation and first transfer. No other conditions. What do you think about that batch of embryos?
Unfortunately, none of those embryos is top quality, but I guess that they still have chance to implant.
And just describe top quality more, because I don't like these words. I mean, I know we use them; they're shorthand for something. But what would you consider top quality then? Use the letters so that they understand, right?
Yeah. So top quality embryos is embryo 5AA, for example. Okay. Yeah. So, but still, if we see embryo BB quality, we transfer such embryos, and they still have a good chance to implant. Not so high as embryo AA, but still pretty good chance, I must say.
Anyone want to say anything different? I mean, if a 5 BB,
I would be very optimistic. Again, I would like this patient in my clinic, and I think she has 30 years old. It's like a donor, and she had overall 5 embryos, and we don't know exactly the quality of the day 3 because we just have the number of cells that is very good. So to me, the overall chance of delivery in this cycle is 80% again.
Okay, perfect. And, it's true. I just want to make a general comment about grading, because I had to give a talk on it last year. And I went back to sort of first principles. We get a little bit hung up on this nomenclature. When I started sort of 20, 25 years ago, we couldn't even agree how to grade embryos. We were giving them just different names, so it made no sense at all. We finally got to a place where we use the same letters and numbers, but it's still somewhat subjective. And every doctor here, every embryologist in the world as well, will know that a baby arose from an embryo that we called bad quality. So don't give up on your embryos. the best way to think about grading is which embryo to transfer first. Or, you know, that's the way you should think of it. Don't start writing them off because you don't like the letters that have been put next to them. That's my advice that I can give you today. So Dr. Ioannis, here's a back to sort of medical stuff. To kickstart IVF, I learned that contraceptive pills are used. Is there any way to do IVF without using the pill?
Depends on the basal FSH and estradiol level on cycle day 2 or 3. So what we do is that we don't give contraceptive pills anymore for the preparation prior to stimulation, because there are some studies that have shown that the implantation rate and the response of the ovaries is not proper. What we do is that we perform a test of FSH and estradiol on day 2. And if we have an FSH level of under 15, for example, we have an older patient, or even under 10 if we have a patient under 35. Or if we have an estradiol level of under 50, then we are ready to perform the stimulation.
Perfect, thank you. Sorry, I was just getting another question. I'm just going to make a comment because I used to work for a company that offered, amongst other things, the endometrial microbiome test. So somebody's written here, which I completely understand because I remember this being a common question from patients. Maybe it's true in other countries too. Patient would say, okay, where can I go to get this test? We'd recommend some clinics, or not recommend, we'd just suggest some clinics that we knew were working with us. They go to that clinic and they say, can I do this test? And the clinic will say, no, only if you do IVF with us. Different words, but that was the meaning. So I don't know if you've had similar experience in Greece, Spain, or Czech Republic, but what I would say to that patient in the UK is go to the testing laboratory that offers that test and say specifically, do you have any clinics you work with who don't do full IVF? Because that's going to be your only option. We can't control what the fertility clinics, you know, say to you or do or offer. I don't think that's right to push you into doing IVF there, but I don't get to control that. So I'm sorry about that. Okay. So now we've got a very specific, on the theme of microbiome still. I'm going to ask Dr. Federica this one. Oh, sorry, I've just lost my questions there. Fusa. Oh dear, it's disappeared. Sorry, I'm going to have to scroll to get to it. Make sure I ask the right question. Right, so fusobacteria or fusobacillus, could that be a factor for endometriosis and therefore have a role in embryo transfer success?
What a question.
The question.
So again, I think that we all learned from the result of the microbiota that the variety of bacteria in the microbiota is very, very wide. And actually, I'm not aware of the relation between fusobacteria and endometriosis, but it is true that also there are increasing evidence that maybe endometriosis is a very black hole from ever, that there are theories on endometriosis and if it's the period and then the menstrual bloods coming inside the peritoneal cavity and etc., and maybe the role of some bacteria altered microbiota, but I'm not able to answer this question if there can be a relation between endometriosis and fusobacteria. I don't know if anybody knows.
I'm just wondering if the right question is endometriosis or endometritis.
Yeah, maybe.
Yeah,
maybe.
Endometritis makes sense actually.
Yeah.
Okay. Yeah. Okay.
And sorry, I should have picked up on that because I was constantly talking to my staff at iGenomics saying, make sure you say endometritis, not endometriosis. Yeah.
Yes.
Yeah. So if it's endometritis, of course, an altered microbiota. It depends of the proportion of the bacteria. If it's in the detrimental of the lactobacillus population, of course, it can make chronic endometritis. It can alter the receptivity.
Perfect, thank you. Right, I think we'll draw to a close because we've pretty much answered all the questions. But I want to end on this, not because it's the most important, but it is interesting. And I think you'll all have an opinion, and I've got an opinion too. So the question is in two parts, and I'll ask each of you, and this is the final question we're going to do, so bear that in mind. So it's about artificial intelligence. So one of the patients has written, or one of the audience has written, I understand it's becoming more prevalent in IVF and IVF clinics. So my two-part question is, to what extent are you using it in your clinic? And it's okay if you say hardly at all, because the second part of the question is, what do you think today its relative importance is? How important is it to run an IVF clinic and improve success rates with artificial intelligence? So let's start as we did at the beginning. Dr. Lenka, let's start with you. How are you using it, if at all, and what do you think its relative importance is today?
We use artificial intelligence at our embryological lab. We started quite recently, several months ago, and I guess that it can help our embryologist, but the embryologist is still the best who can assess the embryo quality.
Okay, thank you. Dr. Federica, how about you?
So far, we don't use artificial intelligence. We use, of course, to select embryos, we use time-lapse. And so we have, of course, parameters that are taken into account, but we don't apply algorithm to the artificial intelligence. We are planning to start in 2025, and I think that it will be helpful in the future. Yeah.
Okay, thank you. That's it. I found the specific question now. Dr. Ioannis, what do you think about artificial intelligence? And
actually, I'm a fan of artificial intelligence. I think that artificial intelligence is the future. We are setting up a collaboration with a company that is based somewhere outside Greece now regarding artificial intelligence. And I think that all these subjective opinions of embryologists regarding morphology of the embryo are going to be replaced, let's say, by the platforms of artificial intelligence. So I really look forward to working on it.
Perfect. Fantastic answer. Well, thank you, all of you. I mean, I think what I would say is, and this relates to that talk that I gave last year, somebody else gave an amazing talk on artificial intelligence. And I said, hey, we only just got to the point where we were using the same words. So, it's a long road forward. I think one thing I would say, and I don't know if any of you doctors or audience have used ChatGPT to just do little tasks and things. And people say, it's going to replace lots of people's jobs. And it may do. But there'll be an equilibrium where some jobs will be lost because they can be done better and quicker by artificial intelligence or a computer, but many jobs will be enhanced by a human doing it using AI. And I think that's what we've just heard from all of the doctors, is the embryologists, and I think the doctors in the future, will be using AI to help them do their job better. Because I think every doctor here and everybody knows in the world of IVF, it's getting busier. There's more tasks to do. There's more forms to fill in. And those are the sort of processes that are better done by machines and by AI. And that's how we should be, at least one way we should be using it, is to give people the space to do the things that they're very good at doing and humans do better, have more time to do those well. So I'm not really afraid of AI. I think it's going to improve what we do. And that's a very specific thing, Dr. Ioannis, that you said, which is to get rid of subjectivity, because I think that will improve standardization and success rates. And the patient's question actually was, is there evidence to suggest that AI can improve success rates of IVF in women aged 48 and above? And I think we already answered it. The human answer was, actually, we don't have any success at that age and above. So AI is not going to make any difference to that. What it is going to do is make us much more efficient and more objective in situations where we can have a good impact. So thanks, everybody. Thank you so much, doctors, for your time and your enthusiasm. I think you've given some amazing answers today. Look forward to seeing the audience again at a future Ask Your Doctor. There's a survey link that I think will be sent to you after the session. And don't forget that it's recorded. So if you missed anything at the beginning, or you want to go back and read stuff or listen to stuff, you can do. So thanks, everybody. And we'll say good night for now. Thank you.
Thank you.
Thank
Bye.
you.
Good night.
Very much. Bye.